Hi, my name is Petar Abadžić. I'm Better's International Sales and Manager Lead for International Markets. Today I want to discuss how better data can improve to better care and how we can use quality data to improve patient outcomes and obviously solve some of the most difficult challenges in healthcare, amongst which are also cancer-related activities. So today, as mentioned, I will be discussing the open data-driven development of next generation of e-health systems. To share some words about Better, we are a company providing software solutions. We're a technology company working on open data digital health platform. I'll be happy to share more details about open data initiatives across Europe and focus specifically on the cases where we are using open data initiatives to solve cancer treatments. Our mission at Better is to improve health and care by simplifying the work of care teams and to accelerate digital transformation underpinned by data for life. Why do we have such a big emphasis on the data is because we want to focus on delivering better patient outcomes, and we strongly believe that the right and quality data presented at the right time in front of the right people can actually lead to better patient outcomes. Better as a company, we support more than 150 clients across 30 countries globally, and we are working together with more than 1,000 healthcare institutions in the global perspective. We have more than 50 plus applications that are running on top of the Better platform, amongst which are the Better Meds and Better platform. The customers that we support range from government entities all the way to smallest of clinics. So we include also works with governments, regions, and different hospital chains, or even individual hospitals and cross-border centers that help improve patient outcomes in different countries and regions. So when we talk about digital transformations, we think that there is a better way forward, no pun intended. So we see that there is a lot of disruption in the healthcare IT market. There are new players, there are new business models, there are platforms, standards, open data, open APIs all over the place. And there are ecosystems of partners that are forming the new ways of how we deliver health and care. So there are common themes that we want to apply when we develop new solutions in healthcare. We need to keep the users in mind at all time. So what do users want? They want an experience of using applications and tools that they are fit in using in their daily lives. Those are fit for purpose apps, secure access, no matter where the clinicians are, and they want to have the electronic communication with teams and patients. The new generations of clinicians will have a lot of digital maturity also from the get-go, and this is what we want to support. But at the end of the day, we need to keep in mind the whole idea is to actually allow the clinicians to spend more time with the patients, not more time behind the screen. The same applies to the patients. The patients want the experience to use the same applications which they use in their daily lives. They want to have the secure access to their data from cradle to the grave. The same information about my health record that is important for me when I'm 3 years of age is as important as when I'm 68 or 70, hopefully one day. So it's important that we have the confidence that care providers have access and accurate presentation and relevant data about us as patients. But how do systems that we have today respond to all of those needs? Unfortunately, we've innovated too much, maybe. Of course, innovation is never a problem, but we see the lack of interoperability between multiple vendors, technologies, and applications. The implementation of new healthcare systems also bears in mind high costs. The interfaces are oftentimes outdated, the design is bad, and we have the missing functionality, which then leads to time-consuming problems and challenges faced by our clinicians. So the quality of data is a very important aspect. If we don't have quality data, it's very difficult that we produce and develop quality systems that can actually help both the clinicians and the patients themselves. So what's happening in today's healthcare IT world? Each application stores data differently. If I'm a patient with a high blood pressure and I'm getting prescribed atenolol, for example, in a hospital app, I would need to have much bigger granularity of data on how I store the information about this prescription. If I'm a general practitioner or a family doctor, then I would have a different way, which is the level of granularity, how to present the data stored about the same prescription. And again, in today's day and age, we all use smartphones, most of us at least, where we want to keep track of the medications that we need to administer. So how do we solve this problem? How do we actually combine all of the information and have different applications talk the same language, have the same underlying data, which allows us then to exchange the data between the applications. This is where open data comes into space. So we did that for different data formats. So if we talk about moving the data from one application to another, the same applications we used 10 years ago are not the applications we want to use today. Technology evolves rather fast. So do we really want to migrate all of the data from our health records from one application to another? We bear the risk of having the data loss. The conversion between application A to application B to application C happens on average on every 7 to 10 years, at least when we talk about big, large enterprise hospital systems and so on. So we've solved that as humanity for some of the data formats. If we talk about images, most of the systems today use DICOM, we understand PACS. This is how we've solved it. For documents, we have HL7, CDA, PDFs. Most of the systems can consume that information. But the area where we see a lot of space for progress is actually when it comes to structured data. This is where we want to rely on open data and open vendor neutral specifications provided by Open EHR. Open EHR stands for Open Electronic Health Records, and Open EHR is an open domain-driven platform. It's a vendor neutral community of clinicians who are explaining to us in the IT space how we should use different clinical data points, what are all the data points associated with certain clinical concepts to allow us to actually create systems that don't need to solve interoperability, but are solving now the interoperability. We are all having the same underlying data models and definitions, how to use clinical data to power the systems of tomorrow. So, as mentioned, the clinical data challenges that we're facing. Data is stored in proprietary formats tied to the application that produces and collects the data. Data is oftentimes duplicated. If I use 2 different apps, do I need to enter my body height, body weight each and every time? Or is this a data point that can be shared or open and understood from all the different applications that use that same data? Difficulty in sharing data between applications, clinical quality of data and validation of the data itself. Changes to the data model, all of this is happening. But what do we as users, as developers also want? We want a semantic architecture, which allows us to have meaning of information and healthcare workflows to be precisely defined. We need to have the ability to convert the information from proprietary legacy sources to common formats, something that is shared across the vendor ecosystem. And we need to have the computability of information by inferencing engines, decision support, and business intelligence. So what is OpenEHR? OpenEHR is an international community of clinicians who are providing an open specification for a health information model. So we believe that the clinical data concepts should be defined by clinicians, and the IT teams should be the ones translating the clinical input into the applications that can help them deliver care in a more appropriate way. So OpenEHR is capable of supporting an open platform ecosystem, which is vendor neutral and technology neutral. We want to separate the data from the applications. The data is what stays about me as an individual, as a patient. The applications that I will use across the next 50 years, hopefully, will change quite a lot. But the same information about me as a patient, this is something that should be persisted irregardless of the applications that collect the same information about me as a patient. So what are the goals of OpenEHR? As mentioned, the abbreviation stands for Open Electronic Health Records, an electronic health record of a single individual which combines information from different care settings. Not tied to a specific application. Data is always available in the same format. We use the same underlying model definitions, and we use the same language on how to retrieve that same data. So if you think about OpenEHR, we talk about very simple concepts. Archetypes. Archetypes are maximum data sets provided by OpenEHR. OpenEHR provides us with clinical concepts that are broken down into multiple data points which we can collect. So for example, here we can see the example of blood pressure and the mind map of how it correlates to the different data points that can be collected about blood pressure. Then, how do we reuse different bits and pieces from blood pressure means that we can develop different applications. But if we use the maximum data set and then don't break the data model by defining different use cases, then we can figure out that for blood pressure, we can have a GP visit application. So you visit a family doctor, you want to collect simple information about the patient. If you are interested in blood pressure, you will only reuse the latest blood pressure measurement, 120/80, systolic, diastolic. But if you are developing an application for a cardiologist, he needs to know much more details about the same blood pressure and definitions. So what's the blood pressure? What's the pulse pressure? What's the cuff size? What's the location of the measurement? So all of these details come from the underlying data model definitions, which is vendor neutral, provided by an open community of clinicians that share these data models and want to have the next generation of systems, e-health systems, sharing the same underlying data models. So where can we find that? We can find that in the Clinical Knowledge Manager. CKM, as an abbreviation, is a library of clinical knowledge artifacts, currently predominantly OpenEHR archetypes and templates. CKM supports the full lifecycle management of OpenEHR archetypes and templates through a review and publication process. It also provides us the governance of the clinical knowledge artifacts. So what do we essentially want to do? If we imagine that this is the typical situation that is faced by multiple hospitals globally, besides their core hospital information systems, they add new applications to their core systems. Some of the applications you might be developing today. So we don't want those applications to be all over the place. We need to deal with patient data. We need to deal with security, privacy of that data. So we need to have the right ways on how we store and how we persist this same data in order to actually have it complement the existing systems. So what we are trying to achieve is to set up a vendor-neutral health data platform using open EHR, so open specification, not defined by Better, not defined by any of the vendors or system providers, but rather by the clinicians themselves. In that way, what we can achieve is to have a platform which uses the same underlying data model definitions and has different applications that can feed off of that same data. So that way, once we collect the data about the patient, it can be reused for different applications. Why? Because we're using one platform approach instead of having multiple systems and then trying to integrate all of those. With the use of the platforms, that allows us, if we use the same underlying data models, we can develop applications faster. We can focus on the front end, on enabling the better user experience, user interfaces, rather than figuring out what are the data points I need to collect about the blood pressure. This is defined by the clinicians. Now you as IT guys, as designers, as multiple diverse professionals, you can actually spend more time in developing the front end of the applications and let the platform solve the data models underneath. So let's dive into some of the use cases focusing on oncology, as some of the topics you will be addressing today is cancer, right? So let's discuss the use case of the Christie NHS Foundation Trust based in Manchester, UK. Christie NHS Foundation Trust is the biggest single-site cancer center in whole of Europe. They are using our Better platform to transform their electronic health record. So to share a bit more details about Christie itself, Christie treats around 60,000 patients per year. They have 3,000 employees and over 140 people in their IT staff. They are one of the 2 trusts in the UK that provide proton beam therapy. They are very advanced in diagnosing cancer and obviously providing treatment for the cancer patients. At the same time, they want to reuse the data. Besides providing data for the operational care, they want to have secondary use of data. They are doing over 650 clinical research studies and trials at any given time. So they want to innovate and figure out how the data can actually help them improve the treatment and the processes associated with it. So what was Christie facing? Christie was facing a lot of great digitalization at their trust, some good user interfaces, but multiple systems, multiple logins. The clinicians can't access the data over the internet. They had low quality clinical data spread across so many applications that store the data in their own format. This is something that we've discussed earlier. So what the trust wanted to achieve, the vision was to get complete control over their data for real-time read, write to the core health record, including research as well. They wanted to build and reuse forms, components, and data once. They don't want to do things over and over again just to have the same outcomes. Obviously, one of the key ideas and goals was to improve and expand patient and care digital services such as electronic prompts, which is patient-reported outcomes and measures, and clinical pathways. And besides that, they want to share everything they develop with other NHS organizations, not just the model, but the technology as well. Some of the forms they develop about the cancer patients, they want other organizations to reuse that as much as possible. So their strategy is based on OpenEHR digital health platform. The idea is to fundamentally change the foundation of the Christie future digital health strategy. They are using our low-code platform and digital health platform to re-engineer their entire electronic health record and 680 forms. The first project, as mentioned, was eProms, and soon enough they are starting to roll out medication management built on OpenEHR standards as well. So this is the outcome that Christie wants to achieve. They want to have verticals that send the data into a single clinical data repository based on vendor-neutral specifications, store all the data in a structured way, and then enable the operational reporting warehouse and other systems to feed off from that same clearly and quality stored data. So here we can see the results of the Christie strategy and how they are still working on the same platform, trying to improve the data quality across the whole trust. For this project, they dedicated a team of 4 developers and 4 engineers, again, and they managed to develop 24 forms within 4 months. So these are just some of the disease groups that they managed to address in this short time frame. What are the benefits, not only the results, but the benefits that the collection of the data in a vendor-neutral and an open format allowed them to achieve? The benefits are clinical visits have been cut by 85% within breast cancer disease group. 66% of time taken to conduct phone reviews is saved. 28% of total review time has again been saved, and we found that 97% of the patients found eProms easy to complete, and 99% of the patients found eProms easy to understand. Besides that, we'll address another use case from Slovenia, where I'm calling in from today. So DORA is a Slovenian breast cancer screening program. The breast cancer screening program is one of the 3 largest screening programs in Slovenia. What's the issue or the challenge that we are trying to solve? The target population is rising. We are all facing the same issues. We have an aging population problem. More of us are getting older, we live longer, but then we need to deal with older patients as the time flies by. Breast cancer has the highest morbidity and mortality rates amongst cancers. So it's definitely an area that we need to focus on, and we need to make sure that we are doing the proper screening across time. According to the WHO statistic, breast cancer incidence is constantly growing. Opportunistic screening does not have quality control and does not guarantee results. The results are not recorded centrally, and comparison of different mammography results is not possible. So what we wanted to do in Slovenia is to reduce the mortality for 25 to 30%, imposing more strict and quality standards. The goal was, again, to document all steps and all procedures associated with every candidate that enters the DORA program. So we started in 2008 and developed according to the available sources in terms of both staff and the equipment. The new strategic plan for DORA was aligned with the European guidelines, following a set of goals that should lead to the reduction of mortality caused by breast cancer by 25%. By 2016, we wanted to provide the necessary infrastructure. By 2017, provide comprehensive invitation coverage of the entire target population. By 2020, we want to have 70% of all the invited patients or potential patients that will be examined. So the project included this. Each screening is evaluated by 2 physicians. Only if both decide without any doubt, the woman is returned to the screening process. All other cases are evaluated through consultations with multiple physicians collaborating. Technical quality is evaluated on multiple levels, additional diagnostics and collaborations with laboratories, multidisciplinary conferences before treatment in order to agree on adequate procedures for every patient, and multidisciplinary conferences analyzing the treatment to suggest further procedures. So what we managed to deliver with the project is to connect the entire registry to the central population registry, which is then tied to the National Cancer Registry. We've set up a call center. The DORA EHR is fully based on open electronic health record. We are supporting the printing of innovations and results for easier understanding of the results by the patients themselves. We are doing mammographies, double-blind screening is mentioned, consensus assessments, and obviously have different statistics and KPI monitoring from all of the data stored in a structured format provided by the international community of OpenEHR. So with this, I want to conclude and wish you all of luck in your developments throughout the next few days. Keep in mind that the systems you develop tomorrow should be vendor neutral, should be providing quality data, and we need to focus on the users. It's not the idea that we have more systems, it's the idea that we have more better quality systems underpinned by data for life. Thank you for listening, and I wish you all a great day. Thank you. Goodbye.